Ladies and gentlemen, esteemed panelists, and distinguished guests, welcome to the second edition of Leaders Roundtable 2023, a collaborative action for health equity. This series is organized by Voice of Healthcare with the support of United Nations Global Compact Network India, Parul University and Parul Sevashram Hospital, and BR Life, a healthcare initiative of BRS Ventures Limited. Today, we are honored to have esteemed experts joining us to shed light on the various facets of this crucial global initiative of universal health coverage. It is much more than just a concept, it's a commitment to ensure that health services are not only accessible, but also of the highest quality for everyone. From promoting financial protection to reaching vulnerable population, UHC encapsulates a comprehensive approach to the healthcare. So, without further ado, allow me to welcome my expert panelists. We have joining with us Ms. Upasana Arora, Managing Director, Yashoda Superspeciality Hospital. We have Dr. Geetika Madan Patel, Vice President at Parul University and Medical Director at Parul Sevashram Hospital. Mr. Joy Chakraborty, Chief Operating Officer at PD Hinduja Hospital and Research Center. We have Mr. Neeraj Lal, Chief Operating Officer, Apollo Hospital, Ahmedabad region. We have Colonel Rajeev Mannali, Chief Executive Officer at BR Life SUT Hospital, Pattom. And we have Dr. Arvind Sharma, Secretary, ISA, and Senior Consultant Neurology at Zydus Hospital, Ahmedabad. I welcome each one of you, gentlemen. So we'll start with our first round of discussion. My first question will be for Mr. Neeraj Lal. Sir, so from your industry perspective, how do private healthcare providers contribute to making healthcare more accessible and affordable, particularly for the marginalized communities?
Okay, thank you so much, Ishan, for this question. I think private and corporate healthcare providers are contributing their bit to manage the marginal society in the country. I think with this scheme, which is PMJY, which was started by Prime Minister Modi, and I think now more than 60 crore Indians is a part of that. So we as Apollo Hospital, Gujarat, since we are in Gandhinagar, we have two cluster which is a part of that, like a cardiology and oncology. If you see our 27% of the total patient which is coming in Apollo belong to this PMJY schemes. So these people from the small section of the society, tier 3 and tier 4 cities like Mehsana, Himmatnagar and all, they can come to Apollo and they can get treated by the same doctor with the same quality. So I think that is a very good platform where public private partnership is there. And I think more and more complex surgeries. I want to quote one example. There was a little girl, 6 year old. She recently got transplantation. That was the first pediatric transplantation in the state, where her mother has given her liver. And after almost a month in the hospital, average length of stay, she's treated now. She was a daughter of Dwarkadish Temple, one of the priests there, and they got treated here, where Prime Minister Relief Fund, Chief Minister Relief Fund, as well as money which is collected by the people, and it has been done. So I think that this is a beautiful example where this girl coming from faraway areas like Dwarka getting the liver transplant from one of the major center of excellence in the state. So I think contribution is there, but at the same time, I think people have to do the what percentage, because I think corporate hospital is here for a business. So I think we have to understand, like we have created a separate ward for them, like special rooms and everything is there. So I think corporate hospital is participating in the scheme, but I think the real problem which I think we have raised in various forum is how to make this scheme more affordable and accessible. But for it is for the hospital also. I think so much of money is outstanding. And if you see different states, so like there was a meeting a few days ago where 600 crore is outstanding from government scheme. So I think that is a thing which is a concern, and I'm sure government of India as well as the state government is doing their bit to clear the outstanding, so that I think these people can get the treatment in a similar way which they get in the government hospitals.
Right. Thank you, Mr. Neeraj. I think that was a really wonderful start to this panel of discussion. Thank you for your wonderful insights. Yes, so Ms. Upasana, my first question for you will be, from your perspective, how do private hospitals like Yashoda Superspeciality play a role in supporting the national goal of universal health coverage, especially concerning affordability and accessibility of healthcare?
Thanks for inviting me for this very important topic. I would like to tell you that Yashoda Super Specialty Hospital is part of Ayushman Bharat Yojana, and we are doing very big procedures like kidney transplant and heart surgeries. So all private hospitals should be part of this, universal coverage health, because if government is launching any scheme, and as a healthcare provider we are not supporting them, then that scheme is not going to be successful. And right now whole world is looking at us because Ayushman Bharat is the biggest and largest healthcare scheme. So I think all private hospitals, like we have done first kidney transplant in Uttar Pradesh in our hospital. So very big gift to that family, because that girl was only 16-year-old and she was a Muslim patient. So when the Eid was there, she came back with her family. So that is how we can create a difference in every family, especially poor who are not able to afford to go to a private hospital. So if private hospital will take this initiative that they will become part of this Ayushman Bharat Yojana, or if other government schemes, so everybody will get the benefit of these universal coverage health.
Thank you for your answer. Colonel Rajeev, my next question will be for you. So, what strategies, in your experience, have been effective in ensuring healthcare inclusivity for the underprivileged communities in your region?
I would like to take on this question, looking at what the central government does as also what the state government does. Uh, as you all know, Kerala is supposed to be a model state as far as healthcare goes, and Kerala model has been talked about quite frequently in various fora. Now, that being what it is, I am trying to look at it from a very different perspective as to how can Mr. Neeraj also mentioned this. How can this be made affordable to all the hospitals who are participating in this uh, joint venture? When we talk about public-private participation, we all know that 70% of the almost 70% of the population uh, prefer to go to private hospitals for various reasons. We're not going to the reasons now. uh, if that be the case, how can uh, this Prime Minister's Yojana and also Ayushman Bharat and similar schemes in the state, how can they all be put together? How can they be made, uh, affordable to patients? Of course, it is already there because there's an insurance scheme working out of this. But there should be an effort to bring in all hospitals across the country into this. I'm talking about the private hospitals, and making it affordable to the hospitals also to provide this service. At the moment, I feel that the rates that have been prescribed for various procedures is well below par. The hospitals really have to be suffering as far as their incomes are concerned or the revenues are concerned to be participative in the scheme. While uh, I say that, I would also like to say that there must be an effort to sort of combine the resources both in the private and governmental sector, which may not be happening at this point in time in different parts of the country. I'm specifically talking about the southern region. There are schemes, there are very well pronounced schemes which are available. But the thing is that how do we put all this together and make it, let's say, when we talk about a public private participation, how do we make it really a very comprehensive participation? I feel since the private sector is investing and they are required to invest quite a bit to run various super specialities and specialities, what the government possibly can do, which is not currently happening. Let the government sector look after the primary and the secondary healthcare across the country and definitely in the states, thereby extending the reach all over the state, all over the country. which may not be the case in most states as of now. Let's say there must be a strategy to have uh, a primary health center at least in a radius of 5 kilometers, so that people can go there, fall back for all the primary requirements, and secondary tier of hospitals like the taluk hospitals and the district hospitals can be around 15-20 kilometers and providing secondary care. So primary and secondary care should basically be looked after by the government with add-ons wherever required from the private sector. And private sector, since that entire sector is investment intensive, must have tertiary and quaternary care looked after by the private sector. Such a division would clearly enunciate that everything is looked after correctly, and maybe the government can contribute towards making all these specialty procedures affordable to the hospitals as well. Right now, that's not the case. That is the point which has already been brought out. So, I would strongly recommend that we have a truly participative venture going between the government and the private sector, public and the private sector. Public sector primarily looking at the primary and secondary healthcare needs of the population, and the private sector augmenting the facilities wherever required, like we saw in the case of the pandemic. It was a fantastic cooperation between the government and the private sector. Something like that, where primary and secondary looked after by the government and tertiary and quaternary care being looked after by the private sector, and all participants being adequately or at least a minimum acceptable level of payment be provided, so that nobody is losing in this game. We have to create a win-win situation for all. I think this would be the way forward and should be the way forward, which can create an ideal healthcare situation in the country.
Thank you. Thank you, Colonel Rajeev. That was a really insightful approach, I must say. Really, I appreciate the answer. Yeah, Dr. Geetika. So my first question for you will be, what strategies can healthcare providers adopt to support the motto health for all? And could you share some insights into the collaborations between educational institutions and healthcare providers to enhance the medical services, especially in the rural areas?
In regards to contribution of the stakeholders and healthcare providers for attaining health for all, and especially sharing the education perspectives. So as we all know, the shortage of doctors in the country is being addressed in a very aggressive manner today, and every district is now going to have a medical college. So as far as we are talking about the number of doctors, which is the first thing which is needed to ensure good healthcare accessibility and services, is being addressed to a large extent. I think the same way we need to address the shortage of skilled paramedics, because healthcare is all about teamwork, right? The doctors alone cannot make it happen, especially in the rural areas and the peripheries where the infrastructure, the resources are minimal. So the skilled paramedics shortage needs to be addressed in a similarly aggressive manner. We very strongly need a council, a centrally governed council, where we can have the paramedics being governed under the education institutions, and that will address the shortage of healthcare teams as a whole. Once we have standardized healthcare teams, then the health and wellness centers, the primary health centers, the community health centers will be able to function absolutely optimally. Now, talking about the role of education institutions, I feel very strongly feel that now, as we have a medical college in every district, it is very, very wise to establish a connectivity with these medical colleges and the primary health centers and the health and wellness centers. Just citing an example, like one medical college be given 10 to 20 of these health centers to with the help of technology to deliver the specialist care. As we all know that with the increase in the number of medical colleges, we will be producing more of MBBS doctors. Of course, we also have Ayush doctors, and all the health centers will now be manned by these medical officers. But if we talk about the specialist care, still I'm very sure that in the next 10 to 15 years, we'll not be able to deliver the specialist care in the rural areas, in the primary health centers. So with the use of technology, it gives us a very good opportunity as education institutions to digitally connect with the primary health centers and the smaller centers, and offer the specialist care at these centers. Also comes a role of a lot of training which can be done. So we all know that in all medical colleges, we have the specialty, super specialty departments, we have EM departments, emergency departments. All medical colleges have skill labs and simulation centers now. So very much we can establish standardized protocols of training for the medical officers and for the nurses, for the paramedics, which can be done in a very, very standardized, protocolized manner, so that the team which is working in the rural areas, in the peripheries, is it's skilled and confident enough to deliver the care at a certain level. And the standard referral protocols are also established, so that the purpose of having more number of medical officers will it gives the justice and productivity by proper training to these doctors. Also, talking about the public health education institutions, we all see that in the rural health centers what happens is that the medical officers are a lot of time occupied in a lot of administrative work, field work. So we very much need a public health management cadre, at least about 4 or 5 primary health centers, which is very much come in the public health policy, the recent one which has been published. So the public health institutions can play a role to strengthen the medical officers at certain levels and establish a cadre of public health administrator who can take care of the administrative part, and the medical officers can focus on improving and enhancing the clinical care in these areas. So I think this way, even the nursing institutions, public health institutions, medical colleges, all these can play a great role in enhancing the kind of clinical care we are giving in these peripheral health centers, which will very much be manned by the basic doctors now.
Right. Thank you for that answer. Mr. Joy, my next question will be for you. So as we are discussing with the rest of your panelists, in your opinion, I would like to understand, how do healthcare providers collaborate with the local stakeholders to tailor healthcare services and address the varying healthcare needs across the different demographics that we see in India? Please.
First of all, thank you, Dr. Nishant, and thanks to Voice of Healthcare and organizers for giving me an opportunity to participate here and talk about a very relevant topic, which is probably the need of the hour. So when we talk about 1.4 billion population, when we talk about affordability, when we talk about accessibility, I don't think it is possible if we continue to work in isolation. So if we really need to collaborate, there are different models. It can be private, it can be private public, it can be any sorts of partnership which can bring synergy and add value in the complete delivery ecosystem. Now, you asked that what kind of things can be developed between different stakeholders. So I'll give you a small example what we have done in our from our organization. And I'm not saying that is the only model what you have, but it can be multiple thing what can be done. So the first thing is your let us talk about, we run a rural program where we have several mobile health unit which is taking care of a lack of population in rural Maharashtra. So when we have done this, what we did, we mobilized the CSR funds and support from the private organizations, and we started catering to those people. Now the outcomes are really encouraging, and we have seen a very good result. The other example, which is in the urban setup, which is very close to our hospital facility in heart of Mumbai, where there is a BMC run managed maternity center, and we are in discussion that how do we take up that maternity center, improve the quality of care, improve the delivery of services in that facility, and which will be uh, contemporary in nature, but at the same time affordable, because government is going to engage us as a service provider, and we are going to be the front end operator. Thirdly, it is not our project, but many other organizations have done outsourcing of lab facility with the government, and government is using them to get better efficiency. Fourthly, I can tell you one of the best example, though may not be very pertinent as on today, that is your during COVID time, we have seen. During COVID time, all of us, we came on the same platform, whether it is lab service provider, whether it is private service provider or government, and all of us from the same platform, we fought against COVID, where even government gave us the list of suppliers who can supply at a negotiated price, so the cost of healthcare remains under control. If some of these continue in coming days, I'm sure that we can work in this ecosystem like a true partner and deliver the best possible value to our beneficiaries, that is our patients. So everybody becomes gainer in the whole process, and we can really meet the dream of healthcare for all.
Thank you, Mr. Joy. Really, really wonderful hearing your views around universal health coverage. My next question for Ms. Upasana would be: what strategies can healthcare providers adapt to support the motto of health for all?
So, as you are very much aware, these days, lots of technology has playing a major role, especially in healthcare, like telemedicine, telepathology, teleradiology. And I was always asking to our, whenever I am getting a chance that I am in a forum and I am speaking, so I am always telling that every big private hospital has to adopt a CSC or PSC of government institute. So what will happen? We will not, create burden on tertiary care. We can treat patients then and there. If somebody is not feeling well, only cold, cough, fever, or some stomach ache, some that kind of small things, that person can go to nearby PHC, CSC, and if private hospitals are doing hand holding, so they will get every treatment, small treatments there. So this will not affect, that person will get worse and then he will land up in a very big hospital. So it will create more problem for the public health sector as well as private health sector. So it is better we should reach to them, and through telemedicine we can reach to them, our super specialist, like someone who is living in a small village. If there is a facility of telemedicine, so super specialist can listen to that patient and give them solutions. Same time, we can, these days drones are also playing a major role. They can collect samples and we can provide them report. Everybody is having internet these days. So these are very small solutions, very small things. If we will implement, like now Yashoda is doing hub and spoke model. We are making a small setups in different places. So my doctors are going there sometimes through telemedicine and teleradiology. We are sending them reports and treatments. So this initiative has to be on larger scale, not only what is happening in private sector. Every hospital is doing in their own way. So there has to be some you can say it's a uniformity. So everybody will play this role. Like we have adopted TB patients. Whole Ghaziabad, Yashoda has adopted. So what is happening? We know how many patients were TB affected, how many, and our center is a step center. So at least we can claim that this much of patients now become cured, this much are in pipeline. Now they are, getting consultations. Sometimes they need some counseling. That is how every hospital has to play a responsibility, because as a healthcare provider, we are not running totally a business model. We have to have some sympathy, empathy, and some social responsibility. So this is from my side.
Thank you, Mr. Pasna, for your answer. My next question for you will be: from an educational's, institutional's perspective, how can partnerships further empower communities to actively engage in healthcare and access medical services?
Yeah, so we all know that this is an age of collaborations and partnerships, and the biggest example of a public-private partnership is right in front of us with PMJY, which is the largest health insurance system across the world today. Along with that, India right now, as per my information, has the largest number of medical colleges in the country, and many of these are private medical colleges. So overall, the partnership when it comes to education institutions, when it comes to delivering the services through such an health insurance scheme, which is available pan across the places in the private institutions as well as public sector, is creating wonders for the country, and it's giving a great opportunity to serve the most needy people. Along with that, when we talk about community partnership, I think the establishment and the cadre of ashas in the community, the people who have come from the community, has done a great job in mobilizing people for accessing the healthcare services. And it's time, I think, further we can play our contribution for strengthening and enhancing the role of ashas. Now they are very much established in the villages in I think across the country, but still their role is limited to a certain extent. Now once they are confident of delivering certain amount of work, we can definitely work on strengthening and enhancing their capacities to at least point of care kind of things, and bringing the people standard referral protocols that can be definitely done with partnership with the education institutions. Apart from that, when we talk about leadership, which brings up the policies, I feel a lot of partnerships is still needed when we talk about making the policies for the PMGY or for many more regulatory policies. It's very important that private sector and private providers are kept in loop, and we have equal participation from both the sectors, so that the private sector being one of the largest healthcare service delivery thing in the country, they also have a contribution in formulation of the policies. And the last but not the least, I would say, is the data. It has become absolutely crucial now to see how we can manage, how we can productively use the data that we have, both from the government and private organizations. So we very much need, I think, data research centers which can establish standard registries, and which can try, at least somewhere they can try to analyze the data. We are seeing a lot of changes in the disease patterns these days, right? Lot of young cardiovascular deaths, new viruses, new bacteria coming in. So it's a high time that we start establishing these research centers across maybe medical colleges, and we start analyzing the data. Most of the places we have HMIs now, we are working on clinical modules. Many hospitals have started digitizing their data, including like our hospital has become completely digital. So at least from the places which have the data in the digital format record, we can start analyzing, because this data is what is going to predict the future, and it's going to help us formulate the policies for the future. So it's high time we start focusing on collaborations and partnership for using the data in the best possible manner that we can.
All right. Thank you for that answer. Dr. Arvind, my next question will be for you. So in your opinion, what do the role the doctors and medical experts play in promoting and supporting universal health coverage, and particularly in ensuring that specialized care reaches all segments of the population? Please. Sir, you're on mute. If you can maybe unmute yourself, please.
You are able to hear me?
Yes.
Yeah. Thank you, Nishant. Thank you, Dr. Nishant, for the invitation and to the Voice of Healthcare. And it's a pleasure to hear the esteemed panelists. And considering about talking about the specialized care, what you are talking about for the universal health coverage, I will point out that how the doctors and experts can make a point is, first of all, there is a huge gap between, as all the panelists has discussed about the public sector and the private sector, about the treatment part. I will go for one of the specialized care. If you see cardiac and the neuro, right, and you see about the primary prevention, there is a lot of lack of awareness about the stroke care in India. And looking at that point, if you see about the treatment strategies, which has been a lot done for the cardiac, it has now come for the acute conditions in neurology also. One of the example for that is stroke, right? In stroke, it is the window which is very important, like 4.5 hours or 9 hours for the thrombolysis. And with the government PMJY scheme, all the government hospitals, almost it all started with AIMS at Delhi, and most of the district hospitals and in the government hospital, the clotbuster drug, the Altiplase, is freely available in the government hospital. So that is one of the how you at a doorstep you provide the treatment which is not reachable to the maximum people, the cost of the drug which has been taken care of, and it makes a huge difference for the specialists who are treating such treatment where it is life-saving, and the disability cost, if you see, is huge in treatment of conditions like stroke. If you don't treat them, and if you treat them with the physiotherapy and other modalities, the treatment goes in a very high cost. So, and another example is we have a collaboration like Indian Stroke Association and the World Stroke Organization, where I am the board member. We have a collaboration with WHO, and one of the initiative which has been done on the Indian aspect with Indian Stroke Association is the Indian Hypertensive Control Initiative, where we are helping all the Anganwadi workers and the peripheral district, where know your blood pressure concept is being generated, and all the patients or the routine public which are coming, the blood pressure is noted. And that is a huge step. If you see most of the acute condition for cardiovascular or the cerebrovascular, that is the most important point, that how many across India know their blood pressure above 80. So these are the factors which I feel that they should go at the and there should be some collaboration about the cost cap for even for the acute condition treatment. If you think about GBS, another treatment which is in neurology, which is being provided free in the most of the government hospitals. So it will make a huge difference. Thank you very much.
Thank you, Dr. Arvind, for that wonderful answer. With this, we'll move over to our next round of discussion. I'll start this round with Mr. Neeraj. So my question for you will be, in your opinion, how can private healthcare institutions work together with public sector to enhance the healthcare accessibility without actually compromising the quality, as we know? Please.
Actually, a public-private partnership is the best model where I think both the organization on the public domain as well as private domain can come together. See, the world, if you see the Mayo Clinic in United States, they're known for collaborative care models. They actively engage research and education partnership. If you see Apollo Hospital in India, they have collaborated with government health program. They're extending the healthcare services to tier 3 and tier 4 cities in the form of villages. If you see the Moorfield Eye Hospital in UK, this is an eye hospital will collaborate with National Health Scheme of UK and partnership into that. Cleveland Clinic is also tying up for medical knowledge and patient care. Even in our country, Sankara Eye Care Foundation, they collaborate with the government healthcare program, and these are all successful programs. Like Indian Stroke Association, in which myself and Dr. Arvind Sharma was part of it, we have developed a advanced as well as a primary stroke healthcare standard. First time in the country after US and Canada, some organization has come up. They have partnered with Government of India. We have launched this standard along with our Union Minister, Mr. Dr. Mansukh Bhai. So we have given him. So I think it is the best model where Indian Stroke Association, along with the Quality and Accreditation Institute, coming on the platform, and they are accrediting the advanced healthcare provider in the stroke as well as the primary healthcare centers. So if this collaboration is there, so we can give a better care to our patient and they can reach the appropriate place in time. So I think this is a model which is happening. Like Apollo, we do Billion Heart Foundation. There is one NGO which work with Apollo, and like in Gujarat only, in Ahmedabad, we have tied up with 14 old age home, where on a regular basis, the team from doctors, nurses, and pharmacists go there. They take care of them. They give them medication on a rotation basis. So I think this some of the successful experiment is happening in our country. Now government has to come on a platform where I think it become a mandate for the private as a corporate hospital to participate. Everybody is doing their bit. I think government need to structure, make in a package where everybody participate. I see actually public-private partnership is happening in all other areas. Like in Surat Municipal Corporation, every flyover has been given to one corporate, and you see the Surat flyover and you see the flyover across the country. They are one of the best managed flyover. So whenever you take this flyover, each flyover is given to one corporate. So they manage, they clean and maintain. So I think similar thing we can do in healthcare, and we can give a good quality care to our patients.
Thank you, Mr. Neeraj. That was a really insightful answer. Moving over, Colonel Rajeev, my next question will be for you. So, what measures do you think beyond hospital centric efforts have proven successful in improving healthcare access and awareness amongst the remote and marginalized population, please?
That's a very interesting question that you posed. I think what needs to be done is popularizing telemedicine to a great extent. A telemedicine facility should be available across the country and even the remotest parts of the country. So, uh, telemedicine centers can be so created that even the most inaccessible areas are covered by a telemedicine center. The number of such telemedicine centers required can be evaluated, and they be open on a district-wise, state-wise, and across the nationwide network, which is well connected, and it's connected to the nearest available, be it corporate, be it private, be it public center, which is looking after that particular area and is providing telemedicine coverage from the other end. So it is, I think telemedicine is the answer for a country like India with its vast population, with its huge geographical spread. And the extent of inaccessible areas in the country in different regions is also so huge. The answer really lies in telemedicine. Now, telemedicine combined with home care. Now, we are talking about a scenario where we are not hospital centric. We have to actually cater for people who are bedridden, people who are elderly, people who require palliative care. You name it, and there is a possibility to extend our home care. The combination of telemedicine under the umbrella of a hospital. There needs to be an umbrella. It can be a government hospital, it can be a private hospital. Telemedicine facility combined with home care can do wonders to the healthcare scenario in this country. What we have not done so far, or what we have not been able to exploit, is the possibilities offered by telemedicine and home care. It is just a matter of how we work out the geography and how we work out the spread of these telemedicine centers and the home care and the hospitals which are to provide the umbrella care. If all these are put together in a very systematic manner, I'm very, very confident that firstly, the congestion in the hospitals, be it primary, secondary, or tertiary, or even coronary, can be reduced to a great extent. There can be a very good system of referral cases being sent to the appropriate centers so that they are not congested. And wherever it requires, immediate level of treatment, uh, primary care or secondary care can be provided by home care. This, I think, is the answer for a country like India. Now, this need not be focused only on curative cure. It could also go down to preventive care. I think what a country like India, with this huge population, and with we gleefully call ourselves the diabetic capital, the stroke capital, and things like that, various other diseases, most of them lifestyle diseases. We need to address the preventive aspect as well. And telemedicine, your awareness classes, your Anganwadis being used as awareness centers and all that, all put together, there has to be a very clear-cut demarcation between preventive cure and curative aspects of healthcare, and ensure that the population is fully into understanding the lifestyle aspects. Uh, Very, very simple things like dietary control can make a whole world of difference to the healthcare, and things like that. So preventive and curative both be treated separately. We must be able to put everything together, all the resources together, to ensure that both these go side by side and we derive benefit from it.
Thank you. Thank you, Colonel Rajeev, for your answer. Mr. Joy, my next question will be for you. So, could you elaborate on some effective collaborations that have positively impacted healthcare accessibility for the vulnerable population? Please.
I think when you say vulnerable population, I assume it is, in one hand, those who are economically challenged, and the second hand, people who have different kind of disease profile which is not managed in a setup which is easily accessible. So now, if I keep both the things together, I can tell you some of the examples in my own Mumbai. I can tell you about whether you take Tata Memorial Hospital, where there are patients who are coming paying for their own treatment. On the other hand, people can avail treatment without paying any expenses for their own treatment. Things have been done completely free of cost. So a model which is very effective and most importantly sustainable one. Then again, if you see in urban setup, again, some of the trust hospitals in Mumbai, they are required to do certain amount of charity and they need to give treatment free of cost. So when that model got developed, and it was not that people have come voluntarily, but definitely by virtue of getting certain privileges, being a not-for-profit hospital, they were asked to do things. But whatever it is, the model is very clear that as you are getting certain privileges, you have to give back to the society certain things. So that is one part of it. Secondly, in Mumbai, there is another facility called Seven Hills Hospital. The hospital came up like a typical private-public partnership model way back around 2015 or 16, and it was doing at that time reasonably well. But just before COVID, because of the issues between the government and public, it didn't government and private organization which was managing it had some rough. But again, during COVID, what happened? The center, which is a so-called local municipality managed center, in that the government stepped to provide care through the private operator. So one of the big private operator took charge of certain number of beds, and they started managing, and that became the biggest or largest center during COVID to manage the critically ill patients. The third example I can tell you that government tied up with the private labs, and even today in some of the big medical college hospitals, they take the support, whereas the charges are just a fraction of what it is in directly in the private lab or in a private hospital. So that is done. On the other hand, in the rural setup, if you go, you will get to see there are plenty of examples where the NGOs or charity organizations have adopted and catering for the betterment of that society, where the quality of care is improving, and very importantly, access, which was a dream at certain point of time, that has gone. So these are some of the, I think, relevant example, a very burning example in front of my eyes, and I thought of sharing here.
Thank you. Thank you, Mr. Joy, for your valuable answer. Dr. Arvind, before we end this second round of discussion, my last question for you. So, how can collaborative efforts between the medical associations and healthcare providers be optimized to enhance the specialized care delivery and obviously aligning with all the goals of UHC, as we know? Please.
Very important question, Dr. Nishant. And as I was talking in the previous question to you about the collaborations between country of ours with the huge heterogeneity of the treatment between the public and the private. But as you see the national and the international initiative, I'm part of the Indian Stroke Association also and World Stroke Organization. When they talk about WHO, World Health Organization, we are part of that in our annual conference of World Stroke Organization with WHO. The HEARTS is the initiative they started for the cardiovascular. And that same has been implemented by the ICMR branch at the Indian Hypertensive Control Initiative. So that is to control the blood pressure. This is how the associations from the top of the line at the international level collaborate at the Southeast Asia and coming to the India. That can prevent a lot of different things. This is one of the which is collaboration between the association. Now coming to our Indian aspect, where connecting to the healthcare organization, to our central ministry, I will take the cue of 2 hour of panelists, Colonel Rajeev and Mr. Neeraj. Mr. Neeraj has spoken about the initiative which Indian Stroke Association taken with the ministry. That is about the quality and the uniformity of one of the diseases, that is stroke, across India. Because everyone was treating this disease in a different aspect, right? And there is a lot of things which are needed from the acute to the chronic to treat stroke. It is not like cardiac that you open the artery and you are not doing the rehabilitation. There is a lot of things which is needed in the rehabilitation part also in this disease. So you have to go to a level of, for the rehabilitation, to a lowest level at the panchayat level or the PSC level where these services are provided. They are treated here with a good treatment. The artery is open in the acute stroke. But what happened to their paralysis part after 3 months when they reach to their village level? Is that facility is provided there or not? That initiative we have also spoken about with the ministry about having the primary health center having these rehabilitation facility of the basic, not only the relatives are doing it. But talking about the acute treatment also, which is done in public and private very differently, is with the Quality and Accreditation Institute. We had a MOU which we have shared with the with our honorable minister, and we developed those standards, the accreditation standard for the primary stroke center and the advanced stroke center. Primary stroke center are those are at the district level where it is blessing in disguise having a lot of CT scan after the COVID. So there are a lot of CT scan at the peripheral centers. So you can have the acute thrombolysis there. So the primary stroke center, thrombalizing those patients and having a MOU with the advanced stroke center. The advanced stroke center who are doing the advanced treatment. So that is a spoke and hub model we are talking about, where you treat acute stroke at an advanced stroke center where can you do the thrombectomy, you can do the thrombolysis, but connecting to the 5 primary stroke center where you're training them for treatment can be provided at the village level. Patients are run to the city where they are stuck in the traffic for the timely treatment of such diseases. So that is how you can cover. I'm talking about one example of stroke to cover how universally you can cover at the district level and treat such patients, and they need not to come to the main center either in the Mumbai or Bangalore or Ahmedabad or Delhi. There are only few cluster of hospitals. Like in Ahmedabad, you see we are 7 or 8 corporate hospitals which are doing the advanced management, but they have got accredited and they are training 5 primary stroke centers where they can act as a hub for the stroke. So that is one. And another thing which Dr. Colonel Rajeev has mentioned, which is a big boom, is the telehealth, which COVID has given us. So that has been budgeted also in, I think, 25th March 2020, where government also has budgeted it and given that telehealth should be done. And it will make a huge difference. For there is no need of a neurophysician to treat a patient for giving a thrombolysis at the peripheral level where the facility is available. They can guide them to do the treatment. Even the physiotherapy, they can guide them for the treatment. So telehealth is very important for all the diseases. To reach as a universal health coverage is a very good modality, but it should not be misused. That is also important. But it's a great example for covering as a universal health coverage. Thank you.
Okay, thank you, Dr. Arvind. So thank you to each one of my panelists for sharing their valuable insights on the different initiatives and the expert recommendations on universal health coverage from each one of you. So as we bring this panel towards a closure, I'd like to start with Mr. Neeraj. Your key take-home and a summarization for the today's panel. Please, sir.
I think what I like to say that there should be a charter like government has made a mandate CSR fund. Every private domain should spend 1% of their profit in the CSR thing. So that become a mandate. So I think in order to achieve a goal for universal health coverage, I think every hospital should own certain villages, certain blocks where they can do healthcare initiative, because I think you cannot deny treatment. So I think there should be a platform where every private or corporate hospital, I think, don't consider the private and public in a different way. They are both same and catering to the similar class of society. So I think that should be the motive, and we should be spearheaded by government in association with state government.
Thank you, Mr. Neeraj. Colonel Rajeev, your take home and summarization from today's panel, please.
I would like to bring in a new dimension which has not been spoken about so far. We very often hear about Ayush doctors being posted in allopathic medicine and things like that. We could use every system of medicine, whether it's traditional, whether it's homeopathy, whether it's whatever it is, Siddha, Unani, any form of knowledge which leads to curative actions should be brought together. Their best possible attributes be analyzed correctly, brought together, and made available at every level, primary, secondary, tertiary. Of course, it may not be there, but bring them all together so that the individual who seeks succor, he can choose, and also the best method for a particular disease can be utilized. And let there be a collaboration also take place between all systems of medicine. Right now, we are taxing the allopathic system very heavily. And we are mostly only talking about the modern medicine or the allopathic medicine as if the traditional knowledge never existed in India. Our wealth of knowledge in the traditional medicine is so good, it's tremendous. So therefore, it must be used. And there must be a system of using it, and not transgression of one system into the other, but making them all collaborate, work together, and work towards prevention as also cure. We very often forget this prevention aspect. What about preventive checkups? Can we do it at the Anganwadi level? How can we do it at the remotest possible areas of the country? And if we spend adequate time, energy, and money on creating this, separating out prevention and cure, and ensuring that there is a preventive checkup at least once a year, which, as part of universal health coverage, every citizen of the country is made to go through an annual checkup. That by itself should cut down your incidences of disease and the burden of disease to a great extent. Secondly, uh, talking about all the things which we had put together, telemedicine, home care, bringing in collaborative effort of all systems of medicines, collaborative effort between the private and the public sector, all this put together, I think there lies the answer for uh, universal coverage in India, which is such a huge country with different terrains across the country, and also the huge population. We need to be really very innovative to get things what we require. We should not be aping US. We should not be aping the West. We should be banking on our own traditional knowledge and invest in that to make things happen in our country the way we want it. Thank you.
Thank you, Colonel Rajeev. Mr. Joy, your key take home and a summarization from today's panel, please.
So I'm going to touch upon, I think, very relevant points have been told by Colonel Rajiv and Dr. Neeraj. But my thing is that if we really need to make it more effective, we need to think about how do you make the model very effective. So today, if you look at it, our healthcare structure, delivery system is not very strong. It is very fragile kind. Like we get patients with a very minor illness or who doesn't require a huge intervention from our kind of structure. They come and knock our door. So if you really need to keep it, you need to have a pyramid approach where the primary care needs to be very strong, where government can intervene and government can get that much stronger than what it is today. And there can be a referral thing. I'm not saying that adopt the same system what we have in the western region, western world, that only they can refer, but there should be a system where a person can go and have the confidence to get treatment there, and whoever needs a very advanced tertiary kind of care, they should come and knock our door. So in that way, the really deserving people will come. Your facility utilization will be for a optimum, and very importantly, the resources which are comparatively costlier in a tertiary care center, those are going to be better utilized. So I think we need to have that uh, kind of thing, which will help us in terms of developing and creating a much better and stronger ecosystem.
Yeah, thank you, Mr. Joy. Dr. Arvind, moving over to you. Your key take home and a summary from today's panel on universal health coverage, please.
So now, I will echo the statements which are given by my co-panelists, and especially lastly with Dr. Joy has said. I will agree to part if we don't empower the primary health centers. If you see, there are patients coming to us which don't need a specialist attention. There are non-specific symptoms which patient, and they are burdening the system where there is no need to go to a specialist, right? And as it is, accessibility and availability of a specialist is so easy. It both ways. It should be, but it should not be for the symptoms and for the treatment which is not needing their requirement. So if you empower the primary health center, district level health centers and it's a huge country, which Colonel Rajeev has said is absolutely correct. And so it is very important to look into matter to empower the primary centers, district level centers, and the state, and how you can do it, which I think the government should have some initiatives with the medical association there at the district level. Indian Medical Association, IMA, is there in each and every district. How the national organization can collaborate with IMA and with the public hospitals there as a PSC or the CSCs, and how the corporate can act as a hub for that. That is a big ask, I agree, but those connections are needed. That networking is needed, which Neeraj also mentioned about when he's talking about the accreditation. So I echo all those statements. Thank you very much for having us.
All right. So with this, ladies and gentlemen, I'd like to bring this panel to a closure. I'd like to thank all the audience who have joined us. I'd like to thank United Nations Global Compact Network India, Parul University and Parul Sevashram Hospital and BR Life for collaborating and organizing. And lastly, I'd like to thank all my panelists, Ms. Upasana Arora, Dr. Geetika, Madan, Patel, Mr. Joy, Mr. Neeraj, Colonel Rajeev, and Dr. Arvind. Thank you for sparing time and stepping up with Voice of Healthcare in collaborating on this Universal Health Coverage Day. Thank you, and Voice of Healthcare really appreciates your time and sentiment towards the health equity. Thank you.